Well, thanks for inviting me. Hopefully you can hear me at the back. I'm a professor of healthcare and workforce modelling, so I'm really keen on mathematics. I've been a scientist for 31 years and a registered nurse for 20. I'm going to talk today about some of the work that we do to show people how complex the work of nursing and other professions is, because it's quite often hidden. And I was really inspired. I've come in just right at the end of your talk and it was fantastic. It's really good. And you're absolutely right, research doesn't have to be big. And in fact, most research is really about moving forward other people's ideas and theories. I think it was Isaac Newton who said, if I've seen further, it's because I've stood on the shoulders of giants. So it's not always about coming up with a massive new innovative idea. It's about improving the things we already do, and I think that's particularly true in healthcare. If you're on Twitter, that's my Twitter handle. I tweet a lot because I travel a lot. So I'm on the train tweeting. I'm keeping a bit quiet today, but because we've got some other things going on. But do talk to me on Twitter if you can't talk to me today and you're interested in what we're doing. So what I do, essentially, is sell professional expertise to decision makers who have to make very difficult decisions about how to spend their money. So I sell the expertise principally of nursing, but not just nursing, to chief execs, finance directors, all sorts of people that have got lots of other pressures. The hardest sell, however, is to nurses, because nurses don't quite believe they're experts in things. And I particularly work with specialist advanced practice nurses. And what we try to do is articulate the complexity of their work and some of the other professions. So quite often the first thing I have to do is convince people that they are worth spending money on. So hopefully you guys coming from maybe a different generation won't be like that. So time will tell. But there's lots of false assumptions about nursing. So from my point of view, nursing is, when I talk to people, decision makers about nursing, particularly people that say we can have X amount of nurses for X amount of patients, which isn't as simple as it sounds. Nursing is seen by many people that are not nurses as a series of tasks that are done one after the other. It's like a line. But actually nursing's a lot more complex than that. There's lots of decision making, there's lots of clinical judgment, and that stuff's pretty much invisible. But it's seen as this series of tasks that occupy time, and then what happens is someone comes around with a clipboard and times people doing things, times them doing tasks, and says, well, you can do this much work. So what we do is we kind of think of a different way of showing that. People assume that nursing is the application of a task-based skill set with little decision making. I'm always really surprised at how, and actually this isn't just nursing, I'm going to talk a little bit about paramedic practice as well. People make clinical decisions every day in practice, but there's quite often assumptions that other professions are making the decisions and nurses are the enactors or enablers of other people's professional decision making, which isn't actually true. The true demand of work is never really modelled, so that's what I spend quite a lot of time doing. And people like Jane Ball in Southampton look at the work that's left undone, which is quite important, because if you want to find out how many people you need to deliver a service, you need to know what doesn't get done as well as what they're able to do. Data collection is mostly linear, so that's the time and motion type stuff with a clipboard. And it's not restricted to nursing. So lots of other professions kind of suffer from this. So a lot of the AHP type professions, and people like paramedic practice as well. But the biggest aspect is this invisibility. So you can kind of find all this stuff in the literature, but decision makers still don't quite get it, and that makes it sometimes quite challenging. So I don't know if anyone recognises that. You've been to San Francisco. It's the building of the Golden Gate Bridge. And it was one of the safest bridges to be built in one of the safest constructions in the 1930s. Because the guy that built it, Strauss, gave people hard hats and he put a big net under the bridge to catch anybody that fell. And fewer people died building that bridge. than any other sort of construction at the time. But what Strauss also did was he understood the value of frontline expertise. So he hired engineers and construction workers that had worked on other things, even though they cost a little bit more, because he knew that would be safer in the long run. And what we don't tell people about nursing is that it's a safety critical workforce. It's not just the kind of deliverance of tasks, but it's about being safe, it's about vigilance, it's about being watchful. It's about knowing when something's going wrong and fixing it. But we're not really good at articulating that aspect of care. Frontline expertise is a good return on investment, and this is what we do quite a lot of. I won't go into too much detail because I'm standing between you, a hot room and coffee. So, but you're more than welcome to have this if you want to look these up. So there's a scheme in Holland called, and the Dutch lady taught me how to say this properly, buurtzorg. At least I hope I've said it properly. Where you have district nurses, the equivalent of district nurses, going out and providing all care for patients. So in this country, what we've tended to do is provide care in little sections. So you have social care doing one thing, district nurses doing another thing, and it's all very fragmented. And actually fragmented care costs more in the long run. These guys do everything for patients, and although they cost more up front, they save more because patients don't need to go to hospital as often. It's replicated in lots of different systems. So what we have, LOS is lengths of stay, and LW2 is left without treatment, which are risk areas in healthcare. So we can see that the proactive nature of nursing has an effect on those things. And those things are quite important. They're important from a safety point of view and a quality point of view, but they're also important from a financial point of view. And as you know, we need to save an awful lot of money. We've got some quality work there. That's the National Cancer Patient Experience Survey. And we can see from that things like specialist nurses. You're twice as likely to have a better experience of your cancer care if you have access to a specialist nurse in cancer. So if you've got any, if there are any aspirational specialist nurses in the audience, that's a tough call of a job, but one well worth doing. And these studies are replicated many times in other safety critical industries, so like the oil and gas industry, aviation, aeronautics, things like that, because they consider something called rookie factor. So having very newly qualified people for providing most of your frontline services is actually more costly than retaining your frontline experts. So what they do is they put more money into retaining their frontline experts. So in the oil and gas industry, you're considered a rookie until about 2 years into an engineering career. They'll do a lot of money to keep you there. In nursing, what we tend to do is take all our experts and make them go into management or education. But we don't pay them to stay on the wards and in the community, which is what we probably should be doing, because it's probably more cost effective. Some stuff from the King's Fund. This is just if you're interested in economics, which I guess everyone who works in healthcare needs to be a little bit interested in economics these days. The current, the previous strategy for saving money in the NHS was something called QIP. I don't know if you've ever heard of QIP, Quality Improvement, Productivity and Prevention. And it ran for about 4 years. And it was really about cutting costs, only cutting cost. And it didn't work terribly well, and this is what the economists at the King's Fund said. Something called investing to save works a lot better, and it's actually a predominant model, I think, in other industries. So what you do is you take guys like you, and you invest in you, and you will return a better return on investment. The thing is, particularly for, I guess, some of you guys, that's going to take a few years to show. And if you know anything about politics, you know we're probably always looking for what's going to happen in the next 3 months, next 3 years. So it's kind of helping people understand the long-term benefits that you can bring, as well as the short-term benefits in terms of delivering a safe service. How to make it visible. So these are the questions that we ask. We go out and find what people really do, and then we model it mathematically. So instead of being a series of tasks, we model it as a much more complex system. Then we look at what contributions people make to patient care and safety, and look at their impact and their effect. We look at, are roles worth having? Some roles are very expensive but are not a particularly good return on investment. Unfortunately, I think then people don't really see the ones that are a really good return on investment. And also, if you're running a really busy NHS trust, you've got lots of other things on your radar. So the way we do it is we look for patterns of work. So this is the specialist nurse work, which is the biggest. It's about 50 million hours of work. It's known as a big data technique. So we look for patterns in people's work. And we're just doing some of that work in the acute sector at the minute. If you want to look at the evidence, or you want to look at any of the papers around this, they're on a website called the ApolloNursingResource.com. It's aimed at the specialist advanced practice nursing community, but there's all kinds of resources on there. So this is how we kind of talk about specialist and advanced practice nurses when we're talking to other people that are not nurses. And we talk about them being specialists and experts. So are you familiar with Benner? Patricia Benner's work? Novice to expert? Kind of, we put it on a continuum like that, and this is the Scottish version of that. Because one of the really big issues we have for specialist nurses in making them visible is that they have loads and loads of different job titles. So you'll meet specialist nurses, clinical nurse specialists, advanced practice nurses, AMPs, NPs, all sorts of titles. But actually, because it's an unregulated level of professional practice in this country, there's no correlation between job titles and outcomes. So that's one of the things we're trying to unpick. It's quite a big piece of work. And this is the kind of complexity stuff that we talk to people about. Being a proactive case manager is something that probably all nurses do. You manage care. It's really important. In fact, most professionals, in fact, the professionals that probably don't do this as much are doctors. They don't manage care as much. So, but what you do is you manage the day-to-day care for people, and it's actually a really poorly understood by decision makers part of the work. So all the stuff about managing risk isn't really particularly well understood. So these are the things that we talk to people about. Have you heard of rescue work? Do you know what rescue work is? So you see something's not right and you'll do something about it. And failure to rescue is when, well, have you heard of mid-staffs? That's probably the biggest and best example of failure to rescue that there is. So this is Isabel. I just thought I'd show you Isabel. Isabel works at the Royal Free in London. She's a consultant nurse in gastroenterology. And she's also the clinical director for that service. So she leads the department. It's a nurse-led service. And she's very impressive. She's got an advanced practice education. So I don't know where you guys are going. But now she's developed that into a leadership position, and she runs one of the best inflammatory bowel disease services in the country. So we talk about Isabel as being a really good return on investment and make people like Isabel's work much more visible. She has really high patient experience, and she provides something called person-centred care in real life. So we talk about really good value for money, and we give examples of that. So this is how we kind of make the invisible stuff more visible to people that might not understand it. But there's still lots of doubt. So specialist nurses in advanced practice, actually like most clinicians, are still invisible. So when people do workforce planning, they don't really think about the reason we have this kind of boom and bust approach to workforce planning in England is because people don't really think about too far into the future. As you know, we've got a shortage of nurses at the minute because we cut back training places a few years ago. So hopefully all you guys will get jobs. But essentially, nursing as a workforce, in fact, most of the non-medical workforce is seen it's seen from a financial point of view, but not in things like policy. So this is transforming primary care. Now this is about keeping, so it's an example, it's a really thick document, it's about that thick, and it's about keeping people over the age of 70 out of hospital through being looked after in the community with their long-term conditions. I think the term nurse is used in this 4 times. And well, there's lots of nurses in the community. In fact, I think a lot more than there are in the acute sector. And there's no mention, well, very little mention of other allied health professionals. So physios, paramedics, all those sorts of people in this document. So it's mostly about GPs. So you have to be visible in policy. And then we kind of see that coming through now. This is a document. This is a report by the chief exec of the. Well, it's a story. The chief exec of the NHS, the new one, Simon Stevens, who says advanced practice nurses are a good value. So we're finally kind of getting a lot of the misperceptions about nursing are kind of starting to break down now. So that's quite a good thing. Contribution's not always recognised. Someone tweeted this to me. So this was from a conference programme. So this person doesn't even have a name. So nursing is still quite invisible, and we kind of need to keep going on with our messaging, I think. So one of the reasons, this is one of my least favourite memes from the internet, that nursing is still invisible, is the way it's perceived by decision makers. So instead of perceiving nursing as a safety critical profession, it's really perceived as this nice, fluffy, kind of hand-holding, empathic bunch of people, which of course, nurses are. Nurses are empathic people. But if you read people like Burnish and Gordon, what they say is nursing is relied on something called the virtue script to tell its story, rather than its expertise. So we espouse our values by the nice people that we are, and not actually what we know. And that's kind of seen us as not being particularly important in the eyes of decision makers, apart from deliverers of care and not decision makers about care. So if anyone tweets me this meme, I'll get really upset. And it's not just nurses. So the next one is a bit gory, this picture, but I think it shows this really well, because I've got paramedic friends who say, the next person that calls me an ambulance driver. But it is a thing, and occupational therapists say, I don't do basket weaving. I've never seen an occupational therapist do basket weaving. I don't know where that comes from, but apparently that's what they're known for doing. I've worked with some fantastic OTs, so yeah, it's a bit confusing. But this is the thing about perception. This is the thing about how professions are perceived by people outside of the professions that make policy and make decisions. So hopefully you guys, even if you're not going to go and do the mathematical modelling stuff and the research stuff, are going to give out the really strong messages about what you do and make your contribution visible. Leadership is another hidden facet that isn't seen very often. So this is part of the leadership part, and this was completely missing in mid-staffs by all accounts. Monitoring standards, teaching other people. We've just seen, a couple of recent graduates, I'm guessing. Fantastic role models. That's leadership. So it isn't about managing a hospital, it's about being an empowered and present leader that people want to follow. How can we help other people understand this complexity? This is kind of the important stuff, right? Nurses use killer phrases to describe what they do. Never, ever refer to your work as basic. Basic nursing care. I don't employ a basic lawyer, to handle or a basic accountant to do my taxes. It is care. It is care, and it is complex. And we need to help other people understand that and not undermine it by calling it basic. Use your knowledge script alongside your virtue script. You can talk about empathy and compassion and all those really important things, but also you develop a body of knowledge as you travel through this professional career. So don't be afraid to use it, and actually if you're using research, even better. I get a lot of emails every day. I get 150 emails every day, and I will get emails with smiley faces on, so professional emails with smiley faces on and written in that sort of comic script and in pink And we can use pink if you're a breast cancer nurse. Other than that, you can't. But I get emails from people, and the opening thing is yo. But this is the thing about acting as a professional towards other professionals, because that's how you get taken seriously generally. It's thinking about what might be undermining. So you want something. What's undermining your argument? People make decisions about services, also make assumptions, and that's what we've really talked about today. The assumptions people make about a lot of the professions that are maybe not accurate. So we all have to do our own little bit, I think, to help people understand the complexity of that work. Unless you tell them otherwise, they will make the wrong assumptions. So the idea is to kind of put me out of a job, so I don't have to explain the complexities through mathematics of everybody's work. Because you guys will do it in the future. So that would be fantastic. And give yourself some time to think. I think it's working in healthcare is a really, really pressurised kind of environment. And having time to think is very, very precious. But it's really important to try and make that time to think and reflect on what you're doing. Because we all know reflection is a tenet of good practice. And there's a reason for that. Because it's so easy to just go into a narrower train of thought about what's going on. And then that can change your perception about how you feel about things. If you'd like any more information, this is our website. It's free. You don't have to sign up. It's called Apollo. So it's really aimed at the specialist advanced practice community. But if anyone aspires to be an advanced practitioner or a specialist nurse, please do have a look. And the evidence for all those roles is on there as well. And there's some other resources, including talking about your work. And that's generic, actually. So message we primarily give to people, healthcare is expensive. Nursing is the biggest part of the workforce. But nursing is a safety critical profession. It is a good return on investment. So that's the kind of message we give. And I'll leave you with a quote from a guy that used to put out oil fires called Red Adair. Thank you.